morning, everybody in Australia who's joining us bright and early on a Sunday morning for another PWRFA Presents webinar. I'm Kathleen Jones. I'm the CEO and the founder of the Prader-Willi Research Foundation Australia. Our mission is to drive research into and access to treatments for Prader-Willi syndrome, and we exist to empower our families to work with clinicians and scientists to bring those treatments to life. Today, we're talking mental health in Prader-Willi syndrome, and I'm absolutely delighted that Dr. Deepan Singh is joining us from New York City and Dr. Maryssa Portelli is joining us from Sydney for this really important conversation. The importance of this conversation is underscored by the number of registrations we've received, and most importantly, the diverse cross-section of our community who has signed up to be part of this conversation today. And they include families, clinicians, professional carers and allied health and industry from Australia, Asia, the US, EU. So we have a global audience today. I want to start by acknowledging the traditional owners of the lands on which we meet. We pay our respects to our elders, past, present and future, and we welcome all the First Nations who are joining us today. And at PWRFA, we really look forward to the day when our First Nations people can access equality of healthcare. We don't usually have a trigger warning, but today we do. Today's webinar is going to include discussions around mental health challenges, and that could include crisis situations and emergency department presentations. Some content could be really distressing for, some of you who have lived experience of those supporting loved ones, although all kinds of mental health concerns. If you do find any part of this conversation today overwhelming, please take care of yourself. So if you need to, seek support from a trusted person or professional, and we've listed the numbers for Lifeline and Beyond Blue on our website. So today I'm going to very quickly tell you about our walks that are coming up, a bit of a community announcement. Then Dr. Singh will give a 5-minute overview of leading on from the conference in August of last year. Dr. Portelli is going to talk about PWS mental health in Australia, and then we'll move forward with our Q&A with a combination of questions that you've submitted previously and then some live questions from families. So our Finding 15 walks are back live in May. We'll be in Melbourne, Sydney and Brisbane. You can sign up here at praderwilli.org.au, Finding 15. We're so excited to have these walks. It's the biggest community event in Australia, and it does bring together, we have doctors come along and scientists come along, politicians, friends and family. Really wonderful day. And it's a great way to raise awareness about Prader-Willi syndrome, engage your local communities, and to, of course, raise funds for more research into for Prader-Willi syndrome. And this year, I'm delighted to say that PWSA are partnering with us. And we'll be sharing some of the funding money with them. So this is a great step forward in terms of united voice for Prader-Willi syndrome in Australia, and we're really excited to be welcoming you there. You can sign up to walk, you can become a fundraiser, you can volunteer for the day, however you like, involved and help us to keep driving more progress in Prader-Willi research. I am pleased to welcome Dr. Deepan Singh, who's going to talk about neurobehavioural manifestations of Prader-Willi syndrome. We were having a slight technical challenge.
Can you all hear me now? Yeah.
Welcome. We can hear you and see you.
Excellent, excellent. So I decided, given that we have limited time and we want to focus our attentions on, on making sure that we have enough time for questions and answers, I decided not to create a slide deck and instead just go over briefly, just an overview of everything, of some of the things we discussed when I was there in Australia, and some of the other things. Now, just as an introduction, everyone who's on the call probably knows about PWS. But just as a quick summary, it is due to the lack of function of a part of the 15th chromosome, long arm of the 15th chromosome, and the most pathogen, the hallmark feature of Prader-Willi syndrome is still hyperphagia, which is an insatiable hunger drive that affects patients with PWS, most patients with PWS. There's also intellectual disability and multiple behavioral challenges that we'll speak about today, and endocrine abnormalities. Hyperphagia is, of course, life-threatening, and uncontrolled food seeking can lead to not only obesity, but also things like gastric rupture, the complications. And then the behavioral challenges are many, in fact, hyperphagia itself should also be considered a behavioral challenge rather than something purely, something that we can only target biologically. So, of course, most of you on the call with loved ones with PWS already know that food security is needed. Locks everywhere, wherever food is stored, strict meal schedules, structured routines, and these ensure that the anxiety level related to food seeking is lessened. And hopefully in Q&A we'll get a chance to discuss some examples. Predictability, of course, is key, which you all, I'm sure, are trying to maintain. It helps with transitions, reduces the likelihood of aggressive outbursts. Empathy can be helpful, but usually when a behavioral event is ongoing, it's important to just focus on making sure no one gets hurt, and we are able to resolve that behavioral event as soon as possible. Now, when I came to Australia, it was an amazing trip. Thank you again for having me. It was amazing, meeting everyone. It's got a strong community which is working hard to uplift the lives of folks with PWS in Australia. We focus on discussing the key behavioral challenges in PWS. We spoke about aggression, self-injury, which is frequently observed. We talked about something called response perseveration, where a negative or a maladaptive behavior is still repeatedly engaged in, despite a lack of reward, and that looks like anxiousness or impulsivity. So we had spoken about that, some of the obsessive compulsive features, sleep disturbances, and then finally we touched upon psychosis as a severe behavioral circumstance that comes out of PWS at times. We spoke about medications which are commonly utilized: low dose sertraline, topiramate, naltrexone for food-seeking behaviors, guanfacine extended release, which was a study that I had conducted, and both as a case series and a double-blind placebo-controlled trial, and it was effective in reducing hyperactivity, non-compliance, non-adherence type of behaviors, and aggression in these in my findings. I am exploring light therapy, so I had touched upon that, on how bright light can reduce excessive daytime sleepiness in PWS. Also spoke about some other options when guanfacine or other medicines are not helpful. That's when you start considering antipsychotic type of medications, risperidone being quite well studied. And then we spoke about another ongoing study that we are conducting here in the US, which is vagal nerve stimulation. And there's a lot of hope in that. Studies are still pending, the larger studies, but I'm very encouraged anecdotally with the findings. So basically, as a final takeaway, there's a lot of hope in folks with PWS. Guanfacine extended release, vagal nerve stimulation, pyramid, there are things which are already existing in the market, right? And then there are new things which are coming down the pipeline. Diazoxide has behavioral benefits as well, which is coming hopefully down the pipeline towards the end of this month. We'll have an FDA response on whether or not it gets approved. And then there are other things. Anything that reduces hyperphagia most likely will significantly reduce all other behavioral problems as well, except perhaps psychosis. So, which seems to have a separate reason behind it. So that's my 5 minutes. I don't want to take away time from Dr. Portelli and others on the call. Yeah. Pleasure to be here. Looking forward to the questions.
Thank you so much, Dr. Singh. And you've touched on some of the questions that we have had to us. And it really is a pleasure to have you join us today. Thank you. And now Dr. Maryssa Portelli from the Royal Prince Alfred Hospital, Sydney. I'd love to welcome you to talk.
I'm going to take control. Good morning, everybody, and thank you for coming out early. I was a bit lucky. It's 8 a.m. in the morning, not 7 a.m. in the morning for me. See if I can find, I have a couple of very brief slides, actually just to give you an update of what the Sydney team, so the Prader-Willi Metabolism Obesity Service that I work for is doing at the moment. I have an intro slide because I'm not nearly as famous as Deepan is. So I have met a lot of you already at the conference, and there is a lovely big bunch of my patients and their families who've actually attended this morning, which is really nice. So I have a very, very small fraction of my time is for the Prader-Willi service based at Royal Prince Alfred, and we see patients from all over New South Wales and the ACT. My main job is the Director of Emergency Psychiatry at Royal Prince Alfred, and so I guess my intersection is dealing with psychiatric emergencies that happen with Prader-Willi. And I am actually on call for all of New South Wales for whenever anybody with Prader-Willi steps into an emergency department. And that has ramped up and sounds as busy as you think it would be. Probably I get phone calls of about 3 or 4 people with Prader-Willi a week who've turned up to crisis services or emergency departments. But that is a legitimate way to call me about advice. And if that's the case and a clinician calls me from those hospitals, we can actually do a behavioural treatment plan. And often Georgina and I will actually come up with a treatment plan together that will keep that person safe and keep that person out of hospital and, keep families and carers happy about what's going on. On that note, skip to the next one. I just wanted to talk about our Prader-Willi service, and I've realized that there is a typo. My computer is auto-corrected and keeps adding an S to Willie. Georgina, who's actually on the call today, I wanted to do a huge shout out to Georgina. Georgina has dedicated her entire career to people with Prader-Willi. Georgina is long overdue in her retirement, but is actually retiring this year. And I can see people already clapping. I actually wanted in this forum to do a huge, huge thank you to Georgina and the decades of work that she has done for Prader-Willi. And I know she can't talk because she's in the background, and just to thank her, our service has beefed up recently. We now have the 2 endocrinologists, we have dietitians, we have me, and we have a GP now, Ahmed, who is lovely and is learning all about Prader-Willi and kind of more that holistic idea of kind of everything that's coming together. It was great to have 3 specialists, but we also have Brendan Yee, who comes in as the respiratory physician who presents at the he sees patients for us as well, and has a really strong interest in Prader-Willi and kind of sleep disorders and daytime somnolence and that kind of thing as part of Prader-Willi. But yeah, it's been really lovely having Ahmed as well, learning all about Prader-Willi, and often he will think about things that, it's great having specialists, but sometimes we can't see the forest for the trees because we're specialists. And it's been wonderful in our team to have a GP go, but have you thought about this? And so that's really the lovely thing about our team, is that every patient is multidisciplinary. It's amazing what things get brought up that a single clinician can't think of on their own. Definitely 6 brains are better than 1. And we don't always agree, but, you know, that's good. And the other lovely thing about our clinic is it's 100% covered by Medicare, so all of our families get it for free. Kathleen?
I think it's a great time. Thanks, Maryssa. It's probably a really good time to add that this week our PWS nurse is starting at the Sydney Children's Hospital Network. So we'll be able to start to, link people into the clinic.
Thank you. And the other thing I wanted to actually talk about is that we did have an existing policy, but we have actually updated the policy. Again, this is mostly Georgina, who does all of these things, and we are eventually rolling it out to all hospitals in New South Wales. It's a compulsory we're working on it being a compulsory policy, so you don't actually have to fight with the ED to follow the policy. It's part of their job to follow the policy. There's a strong advocacy for management under medical teams. So actually our recommendation is that everybody with Prader-Willi gets admitted under the endocrinologist, because they're most likely to understand what Prader-Willi is and how to manage it, and all the kind of unusual and idiosyncrasies that make our Prader-Willi family members and patients so wonderful. And there's really strong advocacy for care in the community and actually creating more community links. So basically in this new policy, endocrine are to be made aware of all Prader-Willi presentations, and if they're admitted, they are to be admitted to a single room, one-to-one nursing, which is provided by the hospital, preferably on the endocrine ward, regardless of the admitting consultants, because our endocrine wards know how to deal with teenagers with eating disorders. They understand the idea of having particular feeding needs. They know how to deal with actually having monitoring of food and bowel charts and all that kind of thing. They understand that really better than any of the other nurses. The tea rooms are to be locked, low energy diet, dietitian involved. And I think a really important part of this policy is if anybody with Prader-Willi is in hospital for more than 24 hours, they need the occupational therapist to come to see them, to keep them occupied, to keep them doing things, to keep them actually intellectually engaged, because when they're not, that's when the aggressive behaviors around food happen. So that's been a new thing. I just wanted to use my 5 minutes to announce that. And I'm happy to hand back over to the rest of the questions. I will stop sharing.
That's terrific. Thank you, Maryssa. So the mental health need in our Prader-Willi community is really clearly huge, and it's marked with great complexity. So the questions that we've received ahead of today's webinar really reflect that incredible complexity. So I'm going to try and simplify things with a bit of a structure around our conversation that thinks about the pathway of progress of mental health issues. And hopefully that means we can answer some questions for the parents of younger children up front as well. And they might actually prefer to leave the conversation before we have conversations around the more complex mental health issues that come with age. So let's quickly just talk about some of the earlier childhood, pre-adolescent issues, and then we can move on to hyperphagia and medication and complex mental health. Look, some of our children see people and have strong imaginary friendships, and they talk to themselves and to these imaginary friends. Is this a risk factor for future mental health issues?
Okay. Maryssa, okay, I can go first, and Maryssa, I'm sure you can add to that. So in child mental health in general, right? Imaginary friends are not seen as pathological unless it comes in the way of their development in some way, right? So folks with PWS and having before a certain age, right? Usually before school age, imaginary friends are accepted as part of symbolic play, and it's not really seen as a problem. Folks with PWS, similarly, they're also on a different developmental trajectory. So they might experience the imaginary friends later in life as well, or later in their childhood as well. And just because they have imaginary friends at 9, whereas someone else has an imaginary friends, grew out of the imaginary friends at 4, that doesn't mean that the 9-year-old person with PWS will also not grow out of it. The only time you start worrying about perceptual disturbances is whether it's not imagined anymore. They're actually experiencing something that we are not. It's not just part of their imaginative play. It's as if they start hearing things that do not exist, or they start seeing things that do not exist. That is when we start getting worried. Maryssa, I'm sure there's a lot to add.
Yeah. So in my past life, so before I went to medical school, I was a developmental psychologist. So I dealt with lots of kids with imaginary friends, and it was a really common reason why pediatricians would send me kids, particularly kids with autism, was probably the group I looked after the most common. And I mean, this comes into the neuro psychiatric or psychological profile of Prader-Willi. So about 40% of all kids will have imaginary friends. And we generally see it, so almost half of all kids will be able to tell you about their imaginary friends. And as Deepan says, they usually kind of peter off as they start having richer friendships, which is about 5. Now, with kids with Prader-Willi, you've got a couple of layers to this, is that, we know 80% will have an intellectual disability. So individuals with intellectual disability hang on to imaginary friends longer, again, because that's that developmental side. Individuals with Prader-Willi, kind of as a general profile, often have visual memory and visual comprehension that is much higher than the other parts of their neuropsychological profile. And so they're more likely to see things and have good memory for seeing things. So they might be able to tell you in really, really exquisite detail what their imaginary friend looks like. But the other thing about imaginary friends is that in most cases, it's actually an adaptive process. Often they're, particularly if you look at kind of the more autism side of the behaviors, which we know that lots of people with Prader-Willi have some crossover with autism, is that it's how they model social interactions. So they may have tea parties with their imaginary friend. They may have someone to play with at the park with the imaginary friend. And we also know that kids that are sick often and in and out of hospital often have trouble making relationships with their peers, because often there's times that they're isolated from their peers. And in that case, having an imaginary friend and modeling social interactions with an imaginary friend is actually a really good thing. But as Deepan says, as people get older, and I guess what I see in some of my teenagers, kind of across the intellectual disability spectrum, is when they're starting to choose to be with the imaginary friend or getting kind of involved with the imaginary friend over real social interactions. And there's the psychosis side of things, but then there's also the social withdrawal side of things, and when they start missing out. But certainly if you've got a 8, 9, 10, 11-year-old, probably even up to about 14-year-old who's still got imaginary friends with Prader-Willi, that wouldn't worry me so much. It's just about whether it starts impacting their functionality and their ability to engage with the richness of life.
Thank you. And are there key early risk factors for mental health issues in Prader-Willi that parents can look for? And if they see them, what can they do anything to reduce the children's risk profile?
So let's start there. The risk factors in PWS would, some of them would be sort of non-modifiable genetic, and some of them are modifiable, right, which would be risk factors for anyone, right? So for example, let's start with things which they're born with, right? So there is a slightly higher risk, for example, of psychosis in individuals who have the UPD type of Prader-Willi syndrome, right? Uniparental, maternal disomy. Now, in another example would be, if someone has, a larger base pair deletion, they are much more likely to have autism and have more verbal, intellectual, academic dysfunction. So there are a few things which are non-modifiable. They're just you need to know the risk and look out for it, and prepare for it. And then there are other things which are modifiable that is a risk for everyone. Trauma is a big one. Divorce in the family can be traumatic to the kids, loss in the family, moves, lack of resources, right? So just by someone not having early intervention services, you can put them behind 2-3 years in their development just by not. So COVID closed down a lot of these resources across the world, and people who were born when COVID was just about getting started, folks, depending on where in the world they were, they really suffered a lot, right? A lot of the resources that would have been available to them were no longer available. So I feel like, again, trying whatever would be helpful to anybody else without PWS is helpful for kids with PWS. And there are a few things which are genetic and non-modifiable, and you have to look out for that in the future. I can talk more if there are follow-up questions, but Maryssa, I'm sure there's more to add.
No, that was great. The only thing I wanted to add is that the factors that impact people without Prader-Willi obviously also impact the people with Prader-Willi, as you said, but often family history. So some of the individuals I have that really do have what is a more classical schizophrenia with Prader-Willi are the people who actually have a family history of schizophrenia. So it's not just the Prader-Willi genes that are in play. It's that we always take a history of what the rest of the family is like, because Prader-Willi, as everybody knows, doesn't inoculate you against getting everything else.
Yeah, I'm so glad you mentioned that, Maryssa. I absolutely agree. And just to piggyback on that, what I've noticed is that the likelihood of our patients with PWS developing symptoms of diseases that run in their families is actually higher. So if you have two kids, one has PWS, one doesn't, and if there's a history of bipolar illness, for example, or a history of Tourette's, for example, I see, the tics will show up a lot more in the child with PWS. And it makes sense because their brain is vulnerable, right? The neuronal connections in their brain and the way the nerves have migrated during early brain development, that is where the problems have started, right? So it's like, if you have a vulnerable brain, it is more likely to have other diseases, right? In addition to the classic hyperphagia, which is why we're here, right?
Thank you. That's a really interesting insight. No one's shared with us prior, so thank you so much. Look, we have discussed the next set of questions are actually around hyperphagia and its relationship to mental health. Deepan, you've already touched on it. Is there anything else that you would like to add? The question was around, the fact that some clinicians actually describe hyperphagia as a form of trauma, and did you agree? And how this might actually impact or influence some of the mental health treatment approaches that families adopt.
Okay, so hyperphagia, my interest in hyperphagia has evolved over the years. When I first started as a youngling in psychiatry, seeing my first patient with PWS, I was very shy to discuss. I felt like hyperphagia should be in the endocrinologist domain, which was wrong, the wrong way of looking at it. Hyperphagia simply is a neurobehavioral manifestation. It's not an endocrine manifestation. It's a neurobehavioral manifestation that occurs because the system of the brain that signals hunger and the same system that also signals satiety, these systems are not working well in folks with PWS. I'll give you a very simple example. There is a disease, a brain condition called craniopharyngioma. It's a tumor that develops in a part of the brain which overlaps with the part of the brain that is affected in PWS, which is the hypothalamus. And the treatment is actually to take away the tumor, remove the tumor, and as part of that surgery, most people will lose part of or all of hypothalamus or pituitary or a combination thereof. And guess what? They might be adults at this point, right? They've had a normal development, everything is fine. You take that part of the brain out, bam, severe hyperphagia, severe, more severe than I've seen in patients with PWS. Like you talk about, trigger warning, right? Knife chases, fridges being broken, doors being broken, like severe hyperphagia. We see that in PWS too. Craniopharyngium, and it's a lot more severe. So that's just a reminder that this is a purely biological kind of condition. So one shouldn't feel it's important to take it in that stride. So, all right, now, why is it important to lock all the, so I get very nervous when parents try to say that I want to give my kid and my child with PWS a normal childhood. I think that's the wrong way of looking about it, right? So, for example, if you have a bike and a car, right? When you're driving a bike, you have to wear a helmet. You don't have to wear a helmet when you're driving a car. Why am I saying this weird thing? When you have a child or a person with PWS at home, it's a mistake if you're not locking the doors, the cabinets and the pantry, because no matter how hard you wish that, oh, I don't see the hyperphagia yet, it will still show up. Okay, now the link between hyperphagia and other behavioral problems. The best, most illustrative example came from a patient of mine who is an adult with PWS at this point, 22 years old. And he told me very clearly, very smart kid, he told me, Dr. Singh, I don't steal food. I never steal food. But if I know that there's food in that cabinet and the door is unlocked, I can't function. I'm not really listening to you. I'm feeling the reason I'm looking hyperactive, the reason I'm shaking, and the reason I'm pacing, the reason I'm not finishing my homework is because that one cabinet is open.
And I actually heard that from one of my 19-year-old things, that exact same thing, Deepan, the other day, is that I had the most awful day, and he actually self-harmed on that day because mum had forgot to lock the cupboard. And poor mum obviously had lots of guilt around that, and it's not her fault. It's a very easy thing to forget. But he had not self-harmed in months, and it was just the anxiety around, I don't think I can control myself about that unlocked cupboard.
Exactly. So
that's so interesting, and it raises some, obviously there's restrictive practices that we won't go into that today, but I do think it's interesting for families to note, because a lot of families do find, our child doesn't have locked cupboards because she doesn't have any food stealing behaviours at the moment. But however, I can see the anxiety. So it's a really important question, and we need to just find ways to be able to implement it in Australia in terms of the NDIS and our restrictive behaviours. But we won't go into that today. Thank you so much. Should we go on to some skin picking and some specific behaviours, particularly talking about skin picking, because we've had quite a few questions on that front. And Dr. Singh, you presented at the Asia Pacific PWS conference on the potential for Guanfacine to moderate skin picking behaviours, and we've had questions around that. What is the top line takeaway for our families regarding Guanfacine?
So Guanfacine, is, in my opinion, as well as what's been shown to be true based on studies, as a safer alternative. Okay, that's an opinion. A safer alternative to antipsychotics for aggression management. I think that's reality. Everyone would accept that to be truth. Then the other thing is that it's the only medicine other than N-acetylcysteine which has been studied and has shown to reduce skin picking behaviors, right? And it's the only medicine that has not been linked with, which reduces aggression without causing weight gain, without increasing the risk for mania. which is what SSRI or mood activation and psychosis, which happens with SSRIs or stimulant type of medications in some patients, or even with some of the newer medicines that might be coming down the pipeline. So we're really kind of, I use it as first line. The big issue is that it does cause an increase in sleepiness. People tend to get used to it, but there's some patients, I would say about 5% of the patients will be just too sleepy to be able to tolerate it, in which case we need to find another alternatives. So for aggression and self injurious behaviors such as skin picking, I consider that as first line in folks with PWS. Now, if someone has if someone has psychosis, guanfacine does not work. That's not the choice. And when I say guanfacine, I specifically mean guanfacine extended release, okay, which is brand name Intuitive in the US, and I think it's the same brand name in Australia as well.
Yeah, we only have extended release in Australia. They didn't approve the other one. I actually do have I have some slides on this, sorry, because I think it's just about the kind of legal side of it in Australia, because it is a bit tricky. Because I agree with Deepan, and I mean, since the conference, I have actually used Guanfacine, but it is a bit tricky getting around it. So in Australia, Guanfacine is a highly restricted medication, which I think is ridiculous because, as Deepan said, is actually a much safer medication than even things like lisdexamfetamine or that kind of thing. Like it's actually extremely well tolerated. And really the only rate limiting thing we have is the drowsiness. But I mean, in the patients I've prescribed, I haven't had that problem yet. In Australia, it is actually classed with all of the amphetamines. So it comes under the same rules that we have about amphetamines, and it's classed as a drug of dependence, even though it is definitely not a drug of dependence, and really just reflects that the people who work for the pharmaceutic benefit scheme have no idea about pharmacology. But that is a much bigger talk that I could rant about for hours, because we have this problem with lots of psychiatric medications. So in Australia, it can only be prescribed by a pediatrician or a psychiatrist. So the endocrinologist can't write it, the GP can't write it. So ADHD must be diagnosed according to the DSM-5 criteria, which is, I'm going to talk about that in a sec too. And it also, there's all these other caveats that basically amphetamines haven't worked or stimulants haven't worked. Now in PWS, that's actually quite easy to get around, because you say that there is a contraindication of the stimulant medication. You can say patient is at risk of psychosis, or patient has had an episode which was consistent with psychosis, and that counts as a reason not to have it. Like that counts as a contraindication. Which is usually what I do. The other thing that's really annoying is that to access Guanfacine, even as an adult who was diagnosed with ADHD at 25, you can't access Guanfacine because you weren't 17 when you got the ADHD, or under when you got the ADHD diagnosis. So all of this is really, really annoying. With things like growth hormone, we can often prescribe them off-label, and they cost more money, but you can still access them. You cannot do that with Guanfacine because it is classed as a drug of dependence. And so in New South Wales, and I'm not as familiar with all the other states, I have to say, the Poisons and Therapeutics Goods Act stop a pharmacy from being able to give a private script. So the pharmacist actually can't give it to you, because I've tried to try and get around this by saying, well, let's private script it. And, family are happy to pay $100 a month. We'll just do it. And when I've spoken to the chief pharmacist of New South Wales, they said, actually, the Act says we can't. So Western Australia seems to have slightly more lax laws compared to the rest of the country. But from what I was able to do a brief search through last night, it seems that every state is almost as bad as New South Wales. And the question of how can we change this? Actually, we can't. It is legislated that is a drug of dependence. You would have to change the legislation. It would be but there is a way around it, which is my next slide. I cannot cannot guarantee that every psychiatrist and pediatrician is going to agree with me on this. This is how I get around the legislation in a perfectly legal way. I've even run it past my medical indemnity provider that it is a perfectly legal way for me to get around legislation. So when we talk about ADHD diagnosis, there's a huge amount of diagnostic overshadowing with PWS and ADHD. Now, pre the NDIS, and as a pediatric psychologist pre-NDIS, we used to not give a shopping list of diagnoses for children because for most things, the actual primary diagnosis, which is the Prader-Willi, covers what we're talking about. And anybody who knew any other clinician you were talking to should know that. So we wouldn't actually give 20 diagnoses. And we used to tease the pediatricians who would give 20 diagnoses that, you know, it was overkill and they didn't really understand what was going on. But lots of so you only need 6 or more symptoms for the DSM-5 criteria. If you have a look at those symptoms on the slide, it's pretty easy to say that the average Prader-Willi child has those symptoms. Doesn't need to be 6 all in the same box. You just look at it and go, let's pick 6. You also have, the DSM-5 says it has to be present before 12 years of age. Because our families are so wonderful at getting early intervention for people with Prader-Willi, often you will have school reports and carers reports and all these things that they were doing this stuff. That proves they were like it before they were 12. The problem is it says traditionally we would say symptoms are not better explained by another disorder. So pediatricians often won't give an ADHD diagnosis because the symptoms are better explained by PWS. But that means it cuts you off from drugs. So because the PBS does not talk to anyone else. So when I do a diagnosis for somebody and write my letters, which go to the NDIS and the Safety Commission, and PWS can audit, the PBS can order it whenever they need to, is that I'll say, this is not a real person. This is a conglomeration of lots of patients. Prader-Willi, UPD variant with associated intellectual disability, hypothyroidism. I will go all the way through and actually say ASD-like behaviors, ADHD behavior, OCD-like behaviors, depending on what that particular person has. And that allows us to access things like fluoxetine if they've got OCD behaviors, or allow us to access risperidone, because risperidone does have a PBS indication for autism, but not for Prader-Willi. It will allow us to access ADHD medications, whether that's Guanfacine, lisdexamfetamine, dexamfetamine, methylphenidate, all of that kind of thing. And then I have to write this blurb in the patient's file in case I am ever audited that says, in my opinion, blah meets the DSM criteria of ADHD with PWS as a predisposing factor and their intellectual disability as an exacerbating factor. So, you know, it's co-diagnosed. It's not covered by everything. Prior to the age of 12, this is the evidence I have that they had all of these symptoms. Usually we would use stimulant medication, but it's contraindicated in this person. Therefore, meets all the legal criteria to access Guanfacine. And I am willing to do that, but I can't guarantee that every psychiatrist out there is willing to do this because this is a huge amount of effort. And there is a question that's come up about risperidone since prior to 12. That would definitely become part of the evidence to be able to say why we should access Guanfacine, because risperidone would have been prescribed for behavior disturbance rather than psychosis. And so you would say, I'm substituting the risperidone for another medication which has a more tolerable side effect profile, in response to Sherry's question. Okay. All right, Maryssa, done. I'm going to take that off.
Thank you. I think we're going to thank you so much. I think we've had a really great conversation, and I can see there's questions coming in and the families are really appreciative. I'll say that we now move into, more of the adolescent and adult mental health challenges. And of course, that's going to start touching on the issues of psychosis and risperidone and medication, and specifically medication for psychosis. So I'm just going to offer any families who may have younger children who may not want to sort of delve into this part of the opportunity to drop off now. Okay, so moving into the teen and adult years, obviously the mental health presentation becomes even more complex, and it can be difficult to discern true psychiatric illness from other medical conditions or environmental anxieties, or triggers for that. How do families start to navigate this complexity and to differentiate between, a true psychiatric illness, a delirium, or an anxiety that's been somehow.
Maryssa, you want to go first?
Yeah, so I guess I've been able to collect this amazing amount of cases in the last kind of 6 months from being the first call from ED. And it is really interesting to see how patients present to the emergency department with, what's the tipping point for people to present. And it is really interesting then to see the trajectory of people, because before that, a lot of the patients I was seeing, they'd already seen a psychiatrist, they were 2 or 3 years in, they'd been on huge amounts of antipsychotics, and a lot of the time we were trying to walk that back because the side effects were just not livable. And by the same token, I've had my own patients that I've been seeing, I guess, for a couple of years now, who 19, 20, 21 start developing some of these more kind of what we could consider psychotic symptoms. And we've been able to kind of see how we manage them. So I think the first thing is that if you're really, really concerned about escalating behaviors and you're worried about safety of that person, then of course it's understandable to be in a situation where the emergency department is the only option. And for some people think that. One of the things that is outlined in this policy that we're putting out is about excluding physical causes, and that touches on the delirium. And I spoke about that in a webinar a few months ago, is that really large proportion of the people I'm seeing who are diagnosed with psychosis, when you actually go through their old notes and actually say, well, nobody did an abdominal x-ray, no one did a urine culture, no one did any of those things. And I am actually seeing people who were diagnosed with psychosis 12 years ago from one episode that resolved, but they then got stuck on antipsychotics all of that time. So I think one of the things to look at is really actually looking at physical causes of the distress, physical causes of the hallucinations, physical causes of the intense beliefs, I think is really important, because we don't want young people on antipsychotics for the rest of their life if actually it was a misdiagnosis from a delirium at the beginning, was the first bit. The second bit is often I'm seeing people being put on, kind of reactively being put on large amounts of antipsychotic because they come to the emergency department, no one quite knows what to do with them. They get put in a mental health unit, and mental health units are the way they are in Australia, I can't speak for the US, but the way they are in Australia are extremely stressful for people with Prader-Willi. They are communal units. They're often shared rooms. There is no control over food, because part of the legislation around autonomy for people in mental health units is that they can have whatever food they want. They can order Uber Eats. They can order anything. You can't restrict people to their room because that's considered to be a seclusion. So they're actually pulled out of their room and made to socialize with everybody else in. So universally, any phone calls I've gotten from mental health wards with people with Prader-Willi in it is that their behavior is 10 times worse in the mental health unit than it was out of the unit. So they get given injectable antipsychotics, which become huge doses of antipsychotics in the community. So part of, I guess, the first thing is in an emergency setting, trying to actually manage this medically, not psychiatrically, if we can, at the beginning, to exclude other things other than psychosis, and to make sure that we actually keep that person as calm as possible so we can use as little antipsychotic as possible. Because with that brain fragility that Deepan spoke about before, also comes with a much higher chance of getting side effects from the antipsychotics. Sorry, I'll hand over to you now because I think we're running out of time.
Thank you, Maryssa. Love to hear from you now too, Deepan.
Thank you. Thank you. So yeah, I mean, listen, that's amazing. In fact, Maryssa, if after this call, when you get a chance, if you don't mind sending a draft of the policies that you were talking about, because we don't have like one standardized policy in the US for our states. So that's a great idea, something we can learn from you guys down under. Yeah, so just many people, just to add a little bit to what Dr. Portelli was saying, many people don't really know what psychosis is. So just like a very brief introduction, psychosis versus neurosis is a very basic understanding of mental illnesses. Neurosis is things like depression and anxiety, where you kind of know that there's something off with you and you feel really upset about, not being in control of your feelings and thoughts, and you get super anxious, have panic attacks, or feel like you're a bad person, get depressed, which can happen in PWS as well. But then psychosis, when you start losing touch with reality, where other people are saying there's something wrong with you and you believe things are just fine, right? Or people are out to get me, others want to hurt me. There's nothing wrong with me. So that's the old distinction between psychosis and neurosis. In practical purposes, when you start seeing this drastic, sudden change in their behavior. So people are not born and stay psychotic forever, especially not folks with PWS. It's a very classic, what we call cycloid psychosis. It's sudden, severe. People usually, have a reduced interest in food, which is very interesting. They stop sleeping or sleep really little, which is the opposite of what their usual behavior is. And they might start saying or believing things which are not real. And sometimes they'll start hearing things. Occasionally, they'll start seeing things that are not real. And often they'll have what is called catatonic features, where they're kind of fixed in certain positions and they're resistant to movement. 5:58 p.m. here in the US, which means that you guys probably have to stop soon too. So I'm gonna shut up. I'm sure there's lots more to add. But psychosis, people get really upset, but unless there are complications like going into a hospital where they just unravel completely, usually with early introduction of antipsychotic type of medications, there's a rapid resolution of symptoms. Within weeks, you expect to come back to normal. Within days, really, you start getting better. Yeah.
Thank you. We've just touched on medication. We are due to be finishing up. Do you have 10 minutes to finish up the conversation about medication before we end the conference?
Yeah.
Is that all right?
Yeah.
Thank you. So that we did, you're starting to touch on medication there, Deepan. And first, I just want to say I love seeing this international collaboration between clinicians. This is what it's all about, working together across the world to try and drive forward medical care and research. So that was just a wonderful moment. We've received a lot of questions about medications, and obviously there's around specific medication. Is there a guide to preferred psychiatric medications for people with Prader-Willi syndrome? So for
Sorry.
Oh, sorry. Is there a guide? So we've had all these questions around medications, and of course some specific. Rather than list all the specific medications we've been asked about, I wonder if you can tell us: is there a guide to preferred psychiatric medications for psychosis?
Maryssa, do you want to speak first?
Yeah, I mean, our medications are slightly different as well. So, I mean, things take much longer to come to Australia. So the tricky thing with Prader-Willi patients is the side effect profile, really. And the side effects of medications often limit what we can use or limit safe doses of what we can use. There is kind of a cluster of symptoms called anticholinergic symptoms, with kind of universally people with intellectual disabilities, but particularly people with Prader-Willi actually are far more likely to get those anticholinergic side effects. And one of the ones that tends to really worry me is that it can cause constipation. So I've inherited a lot of patients on olanzapine and quetiapine who end up with really, really severe constipation. And then that ends up with hospital visits, delirium episodes, all of that kind of thing because of the constipation. So where possible, I do try and avoid those medications. I do differ from Dr. Peter Worth, who is a very, very prominent psychiatrist, intellectual disability psychiatrist in New South Wales, who I've inherited a lot of his patients. And he and I over Christmas had a very rigorous discussion about this over a couple of glasses of wine. because he's just retired, he used olanzapine on everybody with Prader-Willi. His view was that if you had appropriate restrictions, it didn't matter, that the hunger drive didn't matter. And I disagree. However, I do have a couple of his patients in their 50s with Prader-Willi on massive doses of olanzapine who are perfectly fine. So it actually pharmacologically doesn't make any sense, but it is what it is. So, I mean, the more weight gaining medications we worry about, interestingly, with the partial agonist medications, so cariprazine, aripiprazole, bexpiprazole, I have been seeing more of what we colloquially call the lookups, or an oculogyric crisis. One of my families calls it the fairies, of kind of like their eyes get stuck staring at the ceiling and they're kind of a bit all over the place, which is a psychiatric emergency. And so that, again, is a sensitivity. So I think in my view, there's no absolute medications we shouldn't be using, but where possible, using as low a dose as we possibly can. Sometimes in my patients, that has meant having some residual symptoms that are livable to avoid those side effects. So it's a balance. It's that balance. So, some people might say, oh, I get the occasional thought that, I might be being watched, but I'm able to reason with the idea that it's not real. I personally think that's safer than putting on bigger doses that then could end up with a whole lot of problems. But that's always a discussion I have with the person and their family, and talk about, and often have kind of PRNs at the ready to boost up that antipsychotic load if they need it. But that's about having an ongoing relationship with the family. And obviously, in my clinic, patients continue to see me ongoing. So it kind of depends on the setting.
Mm-hmm. Yeah, as far as a resource, I'm not to make a plug, but the fact is that I wrote a book only because I was saying the same thing over and over for 10 straight years in meetings. It was the same thing every time. So I was like, okay, let's just put down everything on paper, and it is. People have told me that it's very easy to read, very easy to understand, approachable. So, and there is a whole chapter on psychopharmacology in PWS. So everything that we discussed today, I don't think there was anything that was discussed today that is not in that book, including oculogyric crisis. So, try that book, because there's no way we can convey everything that we know in 1 hour. Yeah.
Yes.
And we might just drop the title of the book in case anyone doesn't know. We might just drop the title of the book into the meeting chat so that people know what to look up on Amazon.
And I do have to say, I do defer to Deepan, because when I read his book a year ago, it was kind of like, oh, I didn't know that. There was a couple of kind of moments. Yeah, it was really, really helpful. It's really readable. I hope your book sales have gone up, Deepan, because I think all my patients have a copy of your book.
Thank you. No, it's I'm telling you, academic books do not pay the bills, but I'm glad that I can say in one line, okay, we've run out of time, but try my book.
Life goal.
So we run out of time. And I know that, we could probably, our families would love this to go for another 3 hours, and we can't do that. But I did just say to both of you, thank you so much for joining this. Are there we're about to close, but are there any burning questions that families really want answered at the moment? We probably could put one in the chat. If not, we will. Okay. We're looking good. Dr. Singh and Dr. Portelli, it has been a really incredible conversation this morning, an enormous amount of information and expertise, and two very passionate doctors that are really focused on our community and our kids and making a difference to them. We do have one question that's come in about psychiatry support. Dr. Portelli, I think we need to have a conversation. Obviously you're in New South Wales, and I've raised this with you before. How do we start to get more national access to, you know, the limited, and I don't want to say to you because you've got already a full caseload, but how to, you know, leverage your expertise and build capacity across Australia so that our adults and kids can access to psychiatric care. It's a real challenge.
So just to respond to what Susie's said in the chat. So I'm working on an Australia and New Zealand wide network of psychiatrists who feel confident in treating Prader-Willi. Although some of my issue has been that there's some psychiatrists who say they're confident in treating Prader-Willi, and then I see their patients for a second opinion and have a stomach sink moment. But I am working on that. I know that Queensland is quite difficult. Queensland have an amazing amount of psychiatrists who treat Down syndrome, which obviously very different, but they are people who are generally quite kind of compassionate, willing to give a lot of time and willing to learn new things. So I'm trying to tap into the Down syndrome network in Queensland to see if they're willing to kind of form like a peer review group about treating Prader-Willi patients. Long-term planning. In the last 12 months, I have had 12 medical students and psychiatry trainees come through my clinic to learn about Prader-Willi. And Sydney Uni have actually made a stream for their students coming to spend a day with me talking and meeting patients and families with Prader-Willi. And a lot of my families have actually sat down and spoken to these clinicians about their stories. And as of last week, I now have an actual Prader-Willi registrar who is a consultation liaison trainee, who's doing an endocrine liaison now as part of her training. So we do have to think of like 10, 20, 30-year plans. Medical training doesn't happen overnight. But I've really been so pleased by how many of the med students are actually putting up their hands and saying, can I come to the clinic? Which is really lovely. So I'm hoping, even if I don't end up with an army of psychiatrists who know about Prader-Willi, I'll have an army of GPs who know about Prader-Willi.
Thank you. We do have, sorry, Maryssa, if I can, and Deepan, we have a question about a son being on lithium. Be concerned about the son being on lithium?
This is a very long question. This is not
okay.
For 1 minute, but again, I'm sure Dr. Portelli and I, we both have resources. Again, there's a section on lithium. Lithium is, again, it's a very personal choice from psychiatrist to psychiatrist. Usual nowadays, psychiatrists in our generation, Dr. Portelli is from the newer generation of psychiatrists, so she might have a different thought on this. But lithium in the usual dosages given in psychiatric practice over long term can have a major burden of side effect. So, it can be very effective, but I feel like there are safer options. I would not recommend, to the person who's asking this question, Ms. Jones, I would not recommend that you stop the lithium. You need to, it's not an easy one to just stop and ask the doctor to switch to something else. You really want to, think this through, because if your son has pure euphoric mania, which can happen to a few patients with PWS, then lithium is still the drug of choice, But most of my patients, I have never initiated lithium in a person with PWS in over 10 years. But it's not because it's a bad medicine. I just feel like for doctors like us, all we need to have is one really bad incident, and then we know that we want to look for an alternative for that same condition, so that we don't have to go through have our patients go through a severe side. Like one of my patients, anyway, I won't go into details, but the fact is that it's a complicated medication which has a lot of benefits but a lot of side effects, and there might be other alternatives. Consider talking to your treating clinician, preferably a psychiatrist, about alternatives. Maryssa?
Exactly. No, agreed. my other concern is often the monitoring requirement for lithium is that it's very easy for lithium levels to become toxic in people with Prader-Willi. And, you know, that again, that can be a medical emergency. So that would be another layer of why I would be a little bit worried about lithium, particularly when you're with somebody who is food and liquid restricted with Prader-Willi. You're at higher risk of dehydration than the general population, and therefore the risk of toxic lithium levels are higher. So, I mean, it's all a balance, but as Deepan said, if there is like a pure mania, which might be the case if there's a family history of bipolar, then yes, it is something that we would use in that situation, but not if it was for behaviour management.
Okay. I think we're at the risk of going very over time here. So let me say thank you to you both. And if there are people who have questions that are unanswered, we will try to, if it's not Maryssa and Deepan, we will try to connect you with some appropriate experts within Australia. Particularly, I see MH might be Melbourne Hospital. And we will try and get you some answers as best as we can, noting that we can't provide any type of one-to-one clinical advice. All right. Dr. Singh, Dr. Portelli, thank you so much for your time today. And we look forward to seeing you again sometime in the future.
Thank you all.
Everybody, for joining us.
Anyone who can, please come to the US for the international meeting in Phoenix, Arizona. I would love to see all of you. Please, Kathleen, Diane, Maryssa, you must come. You must come to the US. You must come. It's going to be a great meeting. Please come. Yeah.
Thank you.
Take care. Bye. I'll see you in Phoenix.